Hey guys, welcome back to A Scientist Among Us, and this is Hypotheses on Obesity video 3. In this video, I wanted to ask the question, can you use glucagon as a therapeutic to treat obesity? The rationale behind this is that glucagon tells your body to burn its energy stores, whether that's as glycogen or whether that's fat. When your alpha cells in your pancreas release glucagon, it tells your body to burn fat. So, you could think about, okay, can we use glucagon to actually treat patients with obesity? And I looked up clinical trials to see if this has ever been attempted before, and turns out it has. The first clinical trial I want to talk about happened in the 1950s at a maximum security ward of a hospital, and I'm pretty confident they're experimenting on prisoners or they're experimenting on the mentally ill. And I don't condone either of these, but we might as well look at the results because we have the results. So the treatments that were compared were a placebo of 1 ml of what's called diluting fluid and 1 mg of glucagon dissolved in 1 ml of diluting fluid. These are the two treatments that are being compared. The treatments are being injected intramuscularly, and that either means in your arm or in your leg, in one of the muscles in your leg. They're being injected 10 minutes before mealtime. Now, if you remember, this is in a maximum security ward, so meal times are regulated. And the outcomes that are being measured are weight before and after each treatment, average calories consumed before and after each treatment. And this is average calories consumed over 1 day. And they're looking to see if the patients, for example, are less hungry and they're consuming less calories per day when they're on the glucagon treatments. So they're not only looking at weight loss, they're also looking at, can you actually make a patient less hungry? Because that might, in fact, help you to treat obesity. So I have a couple of issues when I was reading this clinical trial. The first one is how many meal times per day, because that if they're injecting 10 minutes before each mealtime, knowing how many meal times per day would tell you what the actual dosage these patients were receiving is. And they didn't really mention that. I would think there's 3 meal times in a day, but the way it was written, I couldn't tell that for sure. The second is which muscle was the site of injection. Remember I said intramuscular injection, so it's either in your arm or it's in your leg, and they didn't mention which muscle was being injected into. And I don't know if this affects the treatment. Perhaps it doesn't, but I would have liked to know which muscle the treatment was being administered to. And, well, yeah, they're experimenting either on mentally ill or on prisoners. And they did say the study was voluntary, so the patients did consent. But if they're experimenting on the mentally ill, are the mentally ill capable of consenting? I don't know. But I suppose it was the 1950s, so they didn't look that far into the ethics, did they? So this clinical trial went for 5 weeks total. The first week, they studied the participants' food choices and understood what their dietary choices were. So if you remember, the treatments were administered before mealtime, and at mealtime, these patients were allowed to eat as much as they want. And as a result, it's important for the scientists running the trial to understand how these patients eat normally, so then they can compare back and see what the treatments are doing. So after this 1 week of studying how the patients eat, there's a second period where some of the patients will receive a placebo and some of them will receive glucagon. And this ran for 2 weeks. And like we said before, they were injected 10 minutes before each mealtime, and the patients were allowed to eat as much as they want. And the patients were monitored for weight before and after. So before this 2 week period, their weight was measured, and after the 2 week period, their weight was measured, and the amount of calories they ate every day was measured. They would basically look at the amount of food they were eating and then back calculate it using tables that tell you how many calories are in each of the foods. And they would take the average and try and figure out per day how many calories were these patients eating. In the second period, weeks 4 and 5, there was a crossover. So during this crossover, if a patient had received glucagon in the previous period, they would now be receiving placebo. And if they were receiving placebo, they would be receiving glucagon. And this would allow the scientists to compare the effect of each of the treatments within the same patients. So they didn't have to compare between two different people. They could compare within the same person what each of the treatments were doing. So this was a double-blind study. That means the staff did not know which treatment they were administering. They just had a vial with a code on it that was assigned to whichever patient they were administering it to. And the patients didn't know what they were getting either. Now, there was a randomization scheme. The randomization scheme, the first initial treatment that they received in weeks 2 and 3 was randomized. So each patient got a random treatment. There was no bias in terms of which patients received which treatment at all. But since in the second treatment period, weeks 4 and 5, whichever treatment they were getting was simply flipped over. That second period's not randomized. It's based on the randomization of the first period. So that's how the randomization scheme worked. So there was coding, meaning that each of the vials had a code on it that allowed somebody who was outside the trial, that was not really running the trial at all, to then decode and figure out which patient received which treatment in which period, and back calculate all the data and figure out what was going on. But during the trial, nobody knew anything except that there was a vial with a code. In this trial, they found that glucagon had no effect on weight over 14 days as compared to placebo. And as you can see, the amounts of weight loss or weight gain are really, if you drank water or if you were dehydrated, that's how much your weight would change. And they didn't really see any major changes indicating that there was actual weight loss or weight gain or anything like that. So glucagon doesn't really affect weight, at least as compared to a placebo. They did find, however, that the patients were eating significantly less. They were eating way less calories than they normally did. And the advantage of a crossover trial means you can compare each of the treatments within the same patients, and then you can look for trends in the same person. So normally, if there was a non-crossover trial, you would be comparing two different people, each of them receiving different treatments. And each of our bodies work a little differently, so it's a bad comparison. But in a crossover trial, you could see the effect of each treatment in the same person, so it's a better comparison. And as we can see, in general, the trend was that the patients ate much less. Now, I have a few questions as to the mechanism of how glucagon is making these patients eat less. So glucagon, as we discussed in the last video, it causes your body to break down its glycogen stores and release glucose into your blood. So this causes a temporary hyperglycemia. And hyperglycemia can cause nausea. If you're nauseous, you'll probably eat less. So my concern is that the effects that they're seeing in this trial was because were the patients nauseous or were they not? And there was no mention of any kind of side effect in the paper. So I'm assuming this was a real effect of glucagon and not just of the nausea that it's causing. But I don't know that for sure. So, it makes me wonder. My second concern was that the dosing frequency is very high. If we're going to translate this into an actual treatment for obese patients, you're not going to expect them to inject a drug before every meal, and that's every single meal for the entire period of time that they're losing weight. That's a lot. That's not practical. So, does glucagon work? The answer is maybe. I don't know if it's just causing nausea and that's why it's making the patients eat less. Does it work in terms of weight loss? Definitely not, at least within the period that it was studied. And so I looked at another clinical trial just to see what was the trend. And in this clinical trial, they actually looked at energy expenditure. So that's basically like they're checking your core temperature and seeing how much your body is burning and what your metabolism is like. And what they were doing was they were infusing glucagon for 10 hours. So once again, this is an impractical dose. And I'll be honest, I didn't read the study fully, but if you look at the abstract, they said that the increase in energy expenditure was only marginal. So once again, this goes back to if we're going to use glucagon as a therapeutic for obesity, it's probably not a very good therapeutic because you need to infuse it for 10 hours straight just to get a marginal effect. That's not what we're looking for in a good drug. You're looking for a large effect at a lower dose because that's just better for patients. So why does this happen? So why is this impractical dosage required? Well, it's probably because glucagon's being degraded. So pharmacology, there's two sides of it. There's pharmacodynamics and pharmacokinetics, and this is both looking at what your body does to the drug and what the drug does to the body. And when you're looking at what the body does to the drug, does to glucagon, the body degrades the drug. And if you measure the amount of glucagon in your blood over time, the body degrades glucagon very, very fast. Glucagon, when it's injected intramuscularly, like it was in both the studies that I was talking about, it has a 26-minute half-life. So that means within 2 hours, pretty much all the glucagon that was injected in your blood, it's completely gone. Your body has degraded and excreted it. And that makes for a poor drug because you want the drug to stick around and actually exert its action for a long time. And I think this might be why this impractical level of dosage is required for glucagon. The reason is probably because glucagon's a peptide and it's vulnerable to proteases. So proteases are enzymes that break peptide bonds. So a peptide is a polyamide, as shown over here. And what a protease does, it disconnects the amide bonds. And when you disconnect the amide bonds, you get a carboxylic acid and an amine. And this effectively cuts glucagon in half and makes it inactive. And this is probably how your body clears glucagon. So, probably cuts up all the peptide bonds, and then you get left with amino acids rather than the whole glucagon. And this is probably why glucagon's not an effective drug. Now, there are ways of increasing your own natural production of glucagon. And one way to do that, for example, is fasting. So this was another clinical trial looking at the increase of glucagon during a fasting period. So when you fast, your body needs to break down its own stores and run on its stored fuel rather than what you're eating, because fasting simply means you're cutting the calories that are coming in. So when you fast, over 3 days, your glucagon is increased and your metabolism's also increased, and your body is breaking down its glycogen and its fat stores, and it's using its own energy. And as you can see over here, they measured glucagon in the blood of fasting patients, and it maximized after a 3-day fast. However, afterwards, if you fast for much, much longer, it kind of evens out. Intermittent fasting is a trend right now. A lot of people intermittent fast in order to lose weight and maintain their health. And this is probably the reason why it works, is because your body's releasing glucagon. So we talked about clearance rates. Turns out the rate that glucagon is cleared, is cut up and excreted from your body, it slows down during a fast. And this is a graph from another study where they looked at the rate of clearance. And as you can see from the bar graph, the rate after a 3-day fast is much, much slower than rate when you're not fasting at all. And if you fast for much longer, for way longer after that, it turns out that it's eliminated even slower. But it's not advisable to fast for very, very long periods of time because eventually your metabolism slows down, and this can cause weight gain as well. So this has been me looking through the literature and trying to understand how glucagon is used as a therapeutic and why it's not a very good therapeutic. And in a future videos, one day I'll get back to other kinds of therapeutics that are actually based off of glucagon. And they've made it so that those glucagon analogs, they don't get cut up by proteases. And because they're protease stable, they remain in your body for longer and they actually exert action. And we'll get to that soon. But until then, don't forget to breathe. And this has been A Scientist Among Us. Thank you for joining me.